My name is Jeff Bumpus. I'm from the University of Louisville in Louisville, Kentucky, and I have no disclosures. I perhaps have one in that I'm a member of the American Board of Otolaryngology Head and Neck Surgery, and none of this presentation represents any views of the board, nor does it represent board preparation material. I would like to thank the American College of Surgeons and Dr. May St. John for inviting me to talk on this very important panel regarding head and neck cancer. In specific, I'd like to review the contemporary role of imaging and biopsies in head and neck cancer. One of the most important things for us to talk about is really imaging regarding the most contemporary methods of imaging: ultrasound, CT scan, MRI, PET CT scan, and then some functional imaging that also has impact on how we manage patients. I don't have time to go over all the history or the nuances of all radiology techniques, as there are textbooks written on that topic. Similarly, with regards to biopsy, I want to talk about the contemporary use of biopsy in mucosal-based biopsy of primary tumors of the upper aerodigestive tract, biopsy of lymph nodes, the pursuit of metastatic disease and where biopsy may be relevant there. And in specific, what surgeons should know about special studies that we would request or discuss with our pathology colleagues, particularly tissue biomarkers such as P16, HPV, Epstein-Barr virus, and now PD-1 and PD-L1 inhibitors or antigens and antibodies that may relate to prognosis or the particular administration of agents and sequencing of therapy. So let's talk about imaging first a bit. Really, ultrasound is one of the new cornerstones of imaging because it can be office-based or it can be done by radiologists in the hospital, depending on the needs of the particular patient. We know that it's a low-risk assessment of nodes and sometimes primary tumors, certainly in thyroid cancer, skin cancer, particularly when looking at the parotid and neck nodal basins of things like melanoma and squamous cell carcinoma and Merkel cell carcinomas. And then with mucosal-based malignancies, assessing the N0 neck in particular to determine if there are nodes that are suspicious or potentially targetable, such that we could more accurately pathologically stage the neck in these types of patients. The most really forward-moving utility of ultrasound is its use in biopsy guidance. And again, this helps us P-stage, as we said. It can also provide enough cellular material that biomarkers can be assessed. So with cytopathology coupled with ultrasound, we can obtain a considerable amount of prognostic information that is actionable. In other words, that would influence the ultimate treatment of a newly diagnosed head and neck cancer. This is true in thyroid cancers too, looking at thyroglobulin and calcitonin in well-differentiated thyroid carcinomas and medullary carcinomas, respectively. So in ultrasound, what we ultimately see, if you look at the left-hand side of your screen on the Transverse Study, most nodes are typically ovoid. They have a fatty hilum, which is readily identifiable. This can be linked also and seen on sagittal scan. However, pathologic nodes become rounded up. They are more heterogeneous with different echogenicities indicating hyperechoic and hypoechoic areas. And this can help with needle biopsy, as we'll see later, in targeting specific areas of a lymph node for perhaps a more accurate cytopathological assessment. And here we do see the demonstration of this and how ultrasound can be quite helpful, both in anatomic guidance and in safety with regards to biopsying lymph nodes. This is a patient who's had a prior thyroidectomy and now has either paratracheal nodal recurrence. We see it is adjacent to the internal jugular vein, close to the carotid artery, but safe pathways for targeting these nodes can obviously be seen by ultrasound. And again, this can be an office-based examination or a hospital-based examination. And that largely is contingent upon your ability to coordinate efforts and the exercise with your either radiologist and or pathologist. Computed tomography or CT scan is our workhorse. It allows great anatomic imaging. It allows us to see bony detail. One of its limitations, or a couple of its limitations, are first that it does really require IV contrast to be optimally used in the head and neck, because we want to understand relationships to the vascularity of the head and neck, the carotid artery and the jugular venous system. And also it allows us to determine if tumors are enhancing. So if we aren't able to use contrast due to allergy, hydration, or renal function issues, it certainly limits the ability to use this. There's also some controversy around the use of CT scan with iodinated contrast, and particularly if evaluating well-differentiated thyroid cancers, because this can saturate the iodine symporters, and it may delay the ability to apply radioactive iodine in an adjuvant setting effectively, or at least in a timely fashion. It's a fast study. In our new environment of highly managed care and highly scrutinized care, it's generally easier to pre-certify and pre-authorize these studies. So they often become our, again, workhorse study. Bone erosion, it is critically good at determining erosion of the maxilla and mandible and skull base. It is inferior in assessing elegant soft tissue invasion, such as perineural invasion. Here we see examples of two phenotypes of head and neck cancer. These are oropharyngeal cancers. The one on the left is this highly cystic lymph node in small primary that is classic for HPV or papillomavirus-related oropharyngeal cancer, whereas this larger primary tumor that is heterogeneous with central necrosis and small, more solid adenopathy is highly classic for HPV-negative squamous cell carcinoma, as illustrated in this nice work by Eric Sturgis and colleagues at MD Anderson. Here we see illustrations of the ability, even on soft tissue windows, to see bony erosion, to see enhancement of a tumor here in the oral cavity and involvement of the masticator space. And certainly on bone windows, we can see the obvious bone erosion here. And even subtle cortical erosion is quite easily seen and manifested on CT scan. MRI scan is far superior at looking at, for example, this minor salivary gland adenoid cystic carcinoma of the palate, to determine that there is involvement of the inferior alveolar nerve and also involvement of V3. The ability to determine the soft tissue margination of the tumor, which might be helpful in both determining surgical margins or in non-surgical or post-operative adjuvant radiation therapy, would be very instrumental in determining treatment volumes. Again, we see elegant demonstrations of involvement of an enhancement of a inferior alveolar nerve in the mandible that proceeds up to V3 and foramen ovale in the cavernous sinus. PET-CT has become even more instrumental in the management of head and neck cancers because it gives us a physiologic assessment of nodes and primary tumor. It's highly useful in determining whether they're in the setting of an unknown primary tumor, where a patient presents with a neck mass, where a potential primary tumor might be, such as this HPV positive tumor involving the base of the tongue and having both ipsi and contralateral nodes. Again, a situation where you might have a positive node be the presenting sign for the symptom or for the patient, and then activity along the tongue base could indicate a primary tumor. Lingual tonsil and tonsillar tissue has variable uptake because inflammation can also cause 5,4-deoxyglucose uptake in these areas. So it has to be judiciously coupled with other clinical information such as biopsies, direct laryngoscopy, observation, palpation, and other armamentarians in our clinical skill set. So modified barium swallow and barium swallow are incredibly important and increasingly important. They can be used in a pre-treatment scenario to determine if people are already aspirating and to possibly predict whether they're at high risk for aspiration after resection of tumor or reduction of tumor volume based on concomitant chemotherapy and radiation therapy or non-operative treatment. It may also help the speech and language pathologist develop an early rehabilitative strategy. It may help them assess progress in this. And also the barium swallow itself or the esophagram can identify late effects of treatment for with chemoradiation, such as cricopharyngeal muscular dysfunction and stricture, which are modifiable factors and can be dealt with the intent of improving swallowing and the patient's quality of life. Biopsy can be mucosal based. It can occur in the office or the operative setting, the old age-old adage of pan endoscopy with biopsy. Now it can be done with flexible scopes with operating channels, which allow us to do some biopsies in the office. It must be adequate, so frozen section can sometimes be used to determine whether we have sufficient amounts of tissue for diagnosis. Small volume biopsies, I would warn you, may often be insufficient for diagnosis, in particular if we're adding biomarker-based assessments. In the office, biopsies can be done by ultrasound guidance, but in the hospital, we can add CT and MRI to help us with our guidance. FNA can be used as the principal method of doing this, but again, it's a small sample. And in select cases, core biopsy may be necessary. In particular, when we're thinking of things that might be treated non-operatively due to patient factors or to suspicion of pathology such as lymphoma, or other pathologies which would not necessarily be managed in an operative fashion. So how do we deal with these tissues, and what do we need to know and what do we need to ask? We need fresh tissue if we're worried about lymphoma, or if we're thinking about electron microscopy and neural tumors, frozen section for adequacy of tumor, and then special studies. These special studies could include P16 for or HPV in situ hybridization for oropharyngeal cancers, EBV or EBR for unknown primaries or known nasopharyngeal cancers, PD1 and PDL1 in the context of the clinical trial, unresectable tumors, recurrent tumors in which we're considering the use of targeted or immunotherapy. Other targets in experimental fashion could be vascular markers, epidermal growth factor, or multi-gene panels such as the Foundation-1 studies. I think in conclusion, I'd like to say that surgeons should be aware of the contemporary applications of ultrasound, CT, MRI, and PET-CT. Surgeons should be aware that biopsies can occur in the office, could be image guided, but needs to be coordinated with good communications with our colleagues in pathology. Appropriate and parsimonious use of imaging is also of paramount importance because we don't want to financially harm our patients by over-ordering tests. And then we need to consider, in particular in conjunction in communications with our pathologist, if we need surface markers, genetic markers, and other predictive or prognostic biomarker assessment to pathologic tissues that are removed. I hope this has been helpful in understanding a contemporary review of imaging and biopsy, and I wish you best in the application of these principles in clinical practice. Thank you very much.